Hello and welcome to another episode of PodcastDX, the show that brings you interviews with people just like you, whose lives were forever changed by a medical diagnosis. I'm Lita.
I'm Ron.
And I'm Jean Marie.
Collectively, we're the hosts of PodcastDX. On today's show, we're talking about Barrett's esophagus with me, Lita.
Hi, Lita.
Hello, fellow podcasters, and hello to our great listening audience.
Lita, can you tell us what actually is Barrett's esophagus? Didn't I hear about this term recently when we were talking about ulcers?
Yes, Ron, I'm glad you were paying attention. According to Mayo Clinic, Barrett's esophagus is a condition in which the flat pink lining of the swallowing tube that connects the mouth to the stomach, that's called the esophagus, becomes damaged by acid reflux, which I have, which causes the lining to thicken and become red. Between the esophagus and the stomach is a critically important valve, the lower esophageal sphincter, otherwise known as the LES, and over time the LES may begin to fail, leading to acid and chemical damage of the esophagus, a condition called gastroesophageal reflux disease, or GERD. GERD is often accompanied by symptoms such as heartburn, regurgitation, that type of thing. In some people, this GERD may trigger a change in the cell lining of the lower esophagus, I could say that twice, causing Barrett's esophagus. Barrett's esophagus is associated with an increased risk of developing esophageal cancer. Although the risk of developing esophageal cancer is small, it's important to have regular checkups with careful imaging and extensive biopsies of the esophagus to check for precancerous cells called dysplasia. If precancerous cells are discovered, they can be treated to prevent esophageal cancer.
And this is a condition that you have been diagnosed with, correct? Barrett's esophagus?
I've got that, and I have been treated off and on for GERD for probably my entire adult life, and now it has developed into Barrett's.
So were the symptoms typical of Barrett's?
No, actually, symptoms of Barrett's are typically frequent heartburn, regurgitation of stomach contents, difficulty swallowing food, and less commonly chest pain. But in my case, my biggest symptom, which we talked about earlier, was burping.
Right.
Right. And how is this condition typically diagnosed?
The only way to confirm the diagnosis of Barrett's esophagus is with a test called an upper endoscopy, and that involves inserting a small lighted tube, an endoscope, through the throat and into the esophagus to look for a change in the lining of the esophagus. Even if the appearance of the esophagus may suggest Barrett's esophagus, the diagnosis can only be confirmed with small samples of tissue, biopsies, obtained through the endoscope. A pathologist will examine the tissue to make that diagnosis.
I actually have a couple of questions. Is it common, and how was yours treated?
As far as frequency, here in the U.S., it is not that uncommon, so I guess it's common. It affects about 1% of the population. The Cleveland Clinic states that the treatment depends largely on the presence of symptoms and dysplasia on biopsies.
Okay.
So Barrett's esophagus without dysplasia means that your provider did not detect precancerous cells, and usually you don't need treatment at this stage, but your healthcare provider will want to monitor your condition. You'll need to have an upper endoscopy every 2 or 3 years. If you have GERD, your healthcare provider may prescribe medications to treat GERD, and these medications decrease the stomach acid, and that protects your esophagus from damage. Lifestyle changes can also help. Sleeping slightly inclined and avoiding eating a very late dinner, that could help. However, if you have Barrett's esophagus with dysplasia, that's the presence of the precancerous cells, your doctor may recommend frequent monitoring or treatment to prevent the cancer from developing. There's also something called low-grade and high-grade dysplasia. Low-grade dysplasia means that you have some abnormal cells, but the majority of them aren't affected. In this case, you may need frequent checks to see if any more changes occur, and you may expect to undergo an upper endoscopy every 6 months to a year. Ablation therapy is also recommended in select patients. High-grade dysplasia, on the other hand, indicates a substantial change in your esophagus lining. With this diagnosis, cancer is more likely. You may need to repeat upper endoscopies more often to look for cancer. Your provider may also recommend treatment, which focuses on removing the damaged tissue, and that includes radiofrequency ablation. That's the most common procedure. It burns off the abnormal tissue using radio waves, which generate heat. Cryotherapy, which uses liquid nitrogen to freeze the diseased parts of the esophagus lining so it will shed off. And that process is similar to how dermatologists freeze a wart off.
Fun.
Yeah. Can't talk.
Endoscopic?
Endoscopic. Thank you, Jean.
Mm-hmm.
Endoscopic mucosal resection. That's a handful or a mouthful.
Oh.
Using an endoscope, your provider can remove precancerous spots on the esophagus lining. And surgery. And if you have severe dysplasia or esophageal cancer, your provider may recommend an esophagectomy, which is a surgery to remove all or part of the esophagus.
Wow, that's a lot to swallow.
Yeah.
Wow.
Especially with the tube in your
keep rolling.
tube in your throat, right?
So in your case, Lita, what's the next step for you?
Well, I'm taking a proton pump inhibitor first thing in the morning, as well as staying with the GERD advisement of not laying down after a meal, not eating large meals, drinking less coffee and tea, avoiding trigger foods, which for me might be burritos. And I need to have a repeat upper endoscopy in a year.
And what happens if the medicine doesn't help?
Some people don't respond to medication, and they may need to start by having a surgical technique called Nissen or Nissen.
I thought it was Nissen, but...
Nissen, Nissen, fundoplication, or anti-reflux laparoscopic surgery. They give the esophageal sphincter some assist by wrapping the lower part of the stomach around the lower end of the esophagus. When surgery is not the right option for the patient, then they might have a transoral incisionless fundoplication, or TIA. The TIA is a device called an Esophagus, ESPHYX.
I'm thinking it's SVX.
Okay, SVX, which is inserted through the mouth, and it creates several folds at the base of the esophagus. This forms a new valve to make up that LES that's weak. There are also two other new procedures that might be used. One is called the Barrett endoclinch system, where the doctor uses an endoscope and puts stitches in the lower esophageal sphincter to form pleats, like on a skirt or a curtain.
Curtains.
The other is a Lynx surgery, LINX, and that uses a ring of tiny magnetic titanium beads wrapped around the LES to strengthen the sphincter.
Well, what are some of the possible risks involved with having surgery?
Well, recovery is slightly different for each type of surgery. Okay. So it depends primarily on whether your surgery is laparoscopic or traditional, which while laparoscopic surgery has a quicker recovery time and less pain than a traditional one, it may not be appropriate for every person with GERD or with Barrett's. Your doctor and surgeon will be able to decide which one is best for you. The fundoplication surgery, that first one, which is the most common, is an open surgery, and it requires about a week in the hospital, at least according to what I researched, and then about 6 weeks before you're able to return to work, unless you're happily retired like I am. The laparoscopic
Oh yeah, and you do nothing. Right.
The laparoscopic fundoplication surgery requires only a few days in the hospital, and the patient is able to return to work after 1 week. There's also less pain involved in the less invasive procedures. Prior to any surgery for GERD or Barrett's, your doctor will try dietary changes and medications. If you don't get relief, then surgery might be suggested.
So we won't really know what the next step is for you until next summer when you have your next upper GI?
Unfortunately, no. So I just keep watching those GERD requirements, like I said, not laying down after eating, taking my medication as prescribed, and then next year we see what's what.
So what are the risk factors for ending up with Barrett's esophagus?
Well, if you like, I can take that one.
Sure, give me a break.
Okay. If you have GERD symptoms for longer than 10 years, you have an increased risk of developing Barrett's esophagus. Other risk factors for developing Barrett's esophagus may include being male, being Caucasian, being over the age of 50, having H. pylori gastritis, so that's bacterial based, or is it viral based? Smoking or being significantly overweight. Factors that aggravate GERD can worsen Barrett's esophagus, and these include smoking, alcohol, the frequent use of nonsteroidal anti-inflammatories or aspirin, eating large portions at mealtime, diets high in saturated fats, spicy foods, going to bed or like you said, lying down less than 4 hours after eating. And lastly, it can be associated with Ehlers-Danlos syndrome with dysmotility or increased sensitivity of the esophagus.
Oh, great. So it's in the genes.
It can be in the genes too, yep.
Well, Lita, what additional tips or hints and advice might you have for someone recently diagnosed with Barrett's?
Well, I got some help from Healthline to answer this. Getting plenty of fiber in your daily diet is good for overall health. Medical research shows that it may also help prevent Barrett's esophagus from worsening and lower your risk of cancer in the esophagus. Controlling your acid reflux with diet and other treatment may help to prevent Barrett's esophagus from getting worse. And the other thing you can do is avoid trigger foods. Trigger foods for acid reflux might vary person to person. Common foods that cause heartburn include fried food, spicy food, fatty food, and some beverages. Here are some common foods to limit or avoid if you have acid reflux or Barrett's. Alcohol, coffee, tea, milk, dairy, chocolate, peppermint, tomatoes, tomato sauce and ketchup, French fries, battered fish, tempura, onion rings, red meat, processed meat, burgers, hot dogs, mustard, hot sauce, jalapenos, and curries. So adjust accordingly.
So basically my whole diet.
Yeah.
Well, Lita, thank you for joining the show today and talking about this. How can our listeners learn more about you? Please tell us.
Okay. Hi, I'm Lita. As an individual, I'm on all social media, LITATOMAS. And as a co-host, we hope you'll learn more about myself and my two co-hosts, Jean and Ron, by checking out our website, PodcastDX.com. And I would like to give a big shout out to our listeners who have brought us once again to the top 5 position in the WeGo Health Awards, the world's largest network of over 100,000 patient leaders. If our listeners have any questions or comments related to today's show, they can contact us at podcastdx@yahoo.com, on Facebook, Twitter, Pinterest, or Instagram. And please tune in next week for our special COVID Guide to Halloween.
And if you have a moment to spare, please give us a review wherever you get your podcast. As always, please keep in mind that this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment before undertaking a new healthcare regime. And never disregard professional medical advice or delay in seeking because of something you've heard on this podcast.
Till next week.